ප්‍රභා සර්ගේ මොකක් හරි ප්‍රශ්නයක් තියෙනවා?
ඒක තමයි මම පොඩ්ඩක් කතා කරන්නේ.
Yes sir, we can hear you.
Okay, you can start from your camera. Okay. Okay. Thank you. Alright.
Yes. And the team.
How many participants can you see?
You like to go from the side. Can you see now?
චූට්ටක් පාත් කරමුනේ සර්. ඔව් පොඩ්ඩක්. මොනේ උඩ හරිය විතරයි.
හරිනේ.
තවත් චූට්ටක් පාත් කරනවා නම් සර්. Right, that's great view. Sir.
Oh.
සර්ගේ ප්‍රසන්ටේෂන් එක මෙහින් අපි ප්‍රසන්ට් කරනවා. සර්ට ඔතනට රිමෝට් කන්ට්‍රෝල් ෆැසිලිටි එක දීලා තියෙන්නේ. සර්ට කෙලින්ම මේ මවුස් එක ටච් කර ස්ලයිඩ් එක ඉස්සරහට යන්න පුළුවන් සර්.
මවුස් එකෙන්ද අර මේ ඇරෝ එකෙන් බැරිද?
ඇරෝ එකෙන් පුළුවන් සර්. wait last one. Varun.
Yes, Lala.
Varun, Professor Jayamini can move the slides from the arrow keys, no?
Yes.
He can, no?
Yes.
Yes, sir. You can do it from the arrow keys.
Okay, that's fine. Thank you.
So we have 35 plus up to now. So I believe that we have a good number in the beginning. Yes, switch on. And, because Varun will take the necessary people according to the yes. That's no problem. Varun, can you show me the number? So once when we have 50, we can.
I just messaged you.
Yeah, I saw that. I need the current, the latest one because one speaker.
Yeah, we'll update you on the chat box. Actually, the voice is going on the live stream. Whatever we are talking here right now is going to the live stream.
Now what? set, and we will just keep for maybe a couple of minutes before we start the session, sir. We'll start.
Okay.
Yes. Okay. Good evening, dear doctor. Good evening, dear doctors. It is with great pleasure that I take this opportunity in welcoming you all to the inaugural CME of Dermakonnect Sri Lanka. Also, let me warmly welcome our speakers, Professor Jayamini Seneviratne, and our moderator, Dr. Janaka Akaravita, for today's program. Dermakonnect Sri Lanka is an educational initiative of Glenmark Pharmaceuticals in association with SLCD. The main objective of Dermakonnect Sri Lanka is to establish continuous engagement with Sri Lanka College of Dermatologists to educate and share the expertise in the therapeutic area of dermatology with peers and different specialties, and also to discuss the most vulnerable dermatological topics on different specialties and to address in overcoming difficulties in clinical practice with a series of virtual CMEs. Without taking much time, may I now hand over the floor to our moderator today, to Dr. Janaka Akaravita, consultant dermatologist and the immediate past president of Sri Lanka College of Dermatologists. Let me also inform that if the delegates have any questions during the sessions, the delegates can write their questions in the chat box, which will be addressed by the speaker in the question and answer session. So thank you very much. And I now take this opportunity to hand over this session to you, sir. Thank you.
Thank you, Lalanka and Prabhat and the Landmark team. It is a special day because this is the inaugural meeting of a series of meetings like this, and that is an important aspect. Actually, Landmark is always supporting academic activities. So I think we don't need, Professor Jayamini doesn't need any introduction to the forum because all of us know who he is, but to keep with the tradition, let me introduce, he is a consultant dermatologist at Lady Ridgeway Hospital. Actually, he is the first appointed dermatologist to Lady Ridgeway Hospital. He has more than 2 decades of experience in Lady Ridgeway Hospital, and he has been the former chairman of the board of study and past president of the Sri Lanka College of Dermatologists and a past president of South Asian Regional Association of Dermatologists. Actually, when Professor Jayamini delivers a lecture, always it is interesting. And today's topic is very much interesting. Whatever experience we have, when we see a patient with fever and a skin rash, always there may be some problem to solve. And before I hand over the forum to Professor Seneviratne, I should remind you to send your questions to the chat box so that we can, at the end, we can discuss with them, Professor Seneviratne. Over to you, sir.
Thank you, Janaka. Good evening, ladies and gentlemen. I must tell you that this is not only a common problem, but my presentation is also a vast one. And I must also tell you that I couldn't include all the entities that give rise to a fever and rash in a child, because it's, as I said earlier, such a vast subject. I also take this opportunity to thank the organizers of the Dermakonnect, and I consider it as a privilege to start the Dermakonnect program, the first one. Can I go to the first slide, please? Now, when you look at this problem, there are a couple of issues that I want to tell you all. One is in clinical medicine, we have to deal with the patient. So the patient may have different components in their illnesses, and here we will be focusing on the fever and the rash. So how do we connect, and how do you ultimately get at the diagnosis? Now, to understand this, you need to understand about fever also. And let me briefly go through about fever. First slide, please. Yeah, this is a child who is currently in the intensive care unit of the LRH. And as you can see, the child is sick. You can see the nasal prongs that had been inserted. The child had fever for a few days and came out with this rash, and which was erythematous. And apart from these two features, there was nothing else to go by. And let me show the progression of the rash. Can somebody move on to the next slide, please? I can't do it from here. Yeah, that's the temperature. So the child had been transferred to LRH from a different hospital. The initial spike had been not so high, and the child seems to recover, but clinically, fever-wise, and then it came back in very high spikes. Now let me show the progression of the rash. Initially, it was erythematous macular rash which blanched, and subsequently the erythema became fixed, purpuric, pustules developed, and some of the lesions ulcerated. Next slide, please. Yeah, you can appreciate the necrosis that is seen here. And there was neutrophil leukocytosis. Next slide, please. Yeah, the erythema became fixed, and soon it was followed by ulceration, necrosis and ulceration. Next one, please. Yeah, there were a few erosions on the lips. And we have seen this entity. This is a child whom we saw about 3 years ago. With the same problem, you can appreciate the similarity of the lesions. The both children had erythema multiforme like lesions, and this is ecthyma gangrenosum. Now, this is a very serious condition, and in clinical practice, you have to make the diagnosis clinically. There's no time for you to do a biopsy and wait for the investigations, etc., etc. You have to convince these children on an aminoglycoside and possibly something like piperacillin or derivative. Yeah, here is another child. You can appreciate the erythema, the pustulation, and also central necrosis. Some of these early lesions may mimic erythema multiforme. So this is caused by pseudomonas, and most of these children have some immunological defect, either possibly severe combined immunodeficiency. Now, how do these microorganisms cause damage? They can cause a direct cytopathic effect. For example, we know that poliovirus damaged the anterior hornset, and also microorganisms produce toxin. A best example is Staph aureus. And then they cause a wide variety of immunologically mediated, the so-called hypersensitivity reactions, which could be type 1, type 2, type 3, or type 4. Some organisms directly damage the blood vessels. Among the most common ones are the meningococci. Of course, certain diseases like leprosy can cause a lot of psychological damage because of the stigma. Now, coming to fever, in Latin it's heat. Pyrexia in Greek is fire. And there are other terms like hypothermia and hyperpyrexia, which we will forget for the time being. As you know, in the human body, heat is produced and disseminated. To control this, there's a thermostat, which is located in the anterior hypothalamus. I'll be coming to those. In clinical medicine, fever is both a symptom and sign, and fevers are also described as part of a disease. Say, for instance, you have heard about black fever, hay fever, yellow fever. Various names are given, and sometimes the fever is not there. The word fever is not there. Say, for instance, in viral infections like measles, mumps, chickenpox, there's no word. It's part of the disease. As a symptom, as you know, fever is of little value unless it is measured and documented serially. Then it becomes a very vital clue in the diagnosis. Especially when you observe the fever pattern, you have to observe its height. Now, if it's a very high spiking fevers, you have to know that there is a bacterial infection, say for instance, or a toxin-mediated illness. Among the toxins are the ones that act as superantigens. Also, one should know, notice the number of peaks per day and observe for specific periodicity. It's also important to know how the fever settles. Sometimes it drastically drops. Say, for instance, when you give IVIG for Kawasaki disease, there's a dramatic drop. So was treatment of malaria in earlier days. It settles by lysis. Another fever sign that is useful in clinical practice is the Faggot sign. That is, usually fevers are associated with a tachycardia, but if the microorganism produces toxin which inhibits the AV node, there is a relative bradycardia. In clinical practice, this is seen in visceral leishmaniasis, brucellosis, and untreated typhoid. The next question is fever a diagnosis or a natural response to an inciting agent. So current thinking is to accept the word febrile response, where fever is part of the compensatory response that occurs as a result of inflammation. The cardinal feature is a rise in the core temperature. And this response involves a number of organs, including the cardiovascular system, central nervous system, endocrine. Liver plays a vital role, as are the immune responses. These are the fever definitions. Now, often fever is classified as mild, moderate, or high grade. These are the standard accepted values. And observation of fever pattern is very of vital importance. As clinicians, we had to look at both available fever pattern as well as the rash and the general condition of the patient in order to arrive at a diagnosis. So this is what is known as continuous fever pattern. It rises in untreated typhoid like a step ladder, and once therapy started, it drops in the same manner, stepwise. Then in intermittent fever, there's a drop towards the normal level during several spikes of the day. It drops to normal in between. Whereas in remittent fever, the difference between the lowest peak and the highest peak would be more than 2 degrees of centigrade, but the bottom trough does not reach the normal. Now, biphasic pattern is also important in clinical medicine, like what I have shown here. There are two types, this with an evening pyrexia type of thing, and the M pattern which we see in typhus. Now, if you see a continuous fever intermingling with periods of normal temperature, where the temperature is, the high temperature is sustained. As you can appreciate here, it doesn't change more than few degrees of centigrade. And if you see this is periodic fever, and you can move on to look for the subtypes of periodic fever syndrome. Critical relevance, high spikes often indicate either bacteremia, immune complex formation, complement activation, or necrosis of cells. These are some of the mechanisms by which malignancy is caused pyrexia. Now, coming to mechanisms of fever, the cells, the liver, and the brain play a key role. As you can appreciate, there are different mechanisms of causation of fever by elevating the thermostat, which is located in the organ vascularis of the lamina terminalis, which is located in the optic recess of the anterior hypothalamus. And it has direct inputs. So since this is located next to the third ventricle, if you bleed into the brain, for instance, into the intraventricular, there will be fever. Similarly, it's also stimulated by various antigens and various molecules of microorganisms like glycopolysaccharides of gram-negative bacteria is the best known one. They have a direct stimulant effect, and also the liver produces prostaglandin E2, which has a direct effect on the OVLT to stimulate and raise it to this level. Once the temperature is raised, the thermostat is raised, the impulses are conveyed to the preoptic area of the brain to create fever by peripheral and central mechanisms. So this structure is one of the 7 cellular structures in the anterior hypothalamus. It's circumventricular, lacks a blood-brain barrier. So if there's a compound in the blood, it reaches the OVLT immediately and is stimulated to raise the thermostat. Then you have what are known as pyrogens, parts of microorganisms, immune complexes, and also a variety of cytokines, those which cause inflammation, the pro-inflammatory cytokines, among which there are 3 key cytokines, IL-1, IL-6, and TNF-alpha. Interestingly, IL-6 play a key role in producing the immediate phase reaction from the responses from the liver, for instance, CRP. So both pyrogens, which could be exogenous and endogenous, and cryogens, which are usually endogenous, try to bring down the temperature. Now, the exogenous pyrogens are often parts of microorganisms, and as I mentioned earlier, superantigens, and sometimes even drugs can act as a pyrogen. So these are the organisms that produce superantigens, Staph aureus and Mycoplasma, and among the viruses, the recent coronavirus. So among the cryogens are the certain cytokines which are anti-inflammatory. For example, IL-10. The drugs are also important for us because they can cause a fever and a rash. And drug fevers result from different mechanisms. One, a direct upregulation of the thermostat, or drugs which cause peripheral vasoconstriction and result in heat loss, or direct stimulants of various, as you know, anesthetic drugs, the organ vascularis of the lamina terminalis. They can also act as a heptide and also stimulate what is known as non-shivering thermogenesis. This is by uncoupling the ATP, ADP mediated heat generation. Now, coming to cutaneous manifestations of fever, depends on the etiology and the duration of the causative agent, which results often in inflammation. And there can be non-specific, which occur as a result of a compensatory mechanism. You know, fever is associated with vasodilatation, flushing, then you have specific features like an exantheme, which in Greek meaning breaking out. So if a rash breaks out simultaneously in several places, that is known as an exantheme. And enantheme is often expressed in the mucous membranes. Often these exanthemes are erythematous. The simple reason that most of the inciting agents, they are viruses or bacteria or parts of their body, give rise to an inflammatory response. So we will be going through a series of cases later on, and the rash can be urticarial, papular, diffuse, polymorphous, etc. Sometimes the rash is followed by various other secondary phenomena. So in my presentation, first I will go through a series of cases of fever and infection, and then a series of fever and inflammation. Let us go through some viruses. And in the case of dengue, you see islands of normal skin in the background of diffuse erythema. This is as a result of viremia, and this is classically seen in the convalescence. Chikungunya often cause a congenital infection, and these babies have a lot of changes on the skin of the face, especially the nose, and these lesions become very quickly pigmented. And in the case of chikungunya, which the fever chart is shown here, often you see the saddle back. That is, there's roughly about a day of fever-free time, and from which there can be few spikes again. Now, that often indicates that the virus is replicating again. A similar pattern is seen in dengue and Kawasaki also. In chickenpox, in neonates, you don't see the classical dew on rose petal appearance. Instead, you see saffron on rose petal appearance. And compared to grown-up children, neonatal varicella is a devastating illness with multi-organ involvement, and it's imperative that you give IV cyclo for these children. Coming to enanteme, this is the enanteme of rubella. This is the giant enanteme, which is purpuric seed in some patients with infectious mononucleosis. And in herpangina, which is caused by an enterovirus, this is all you see on the posterior part of the mouth, on the soft palate, and the pharynx, as well as the posterior aspect of the tongue. So by the time these patients come, the fever has settled, so you will not be able to notice the fever pattern. Now, the other group of enteroviruses, apart from the hand-foot-mouth disease, I think I have few slides. When you have infection with, sometimes you see acute infections with other viruses, especially parvovirus. Acute presentation can give rise to edematous feet and hands, palms and soles, which is known as the papulopurpuric love and sock syndrome. And in grown-up children who are usually affected, there's considerable tenderness, and they often find it difficult to walk. So that's caused by parvovirus. Here is another child. It's rare to see the involvement of the dorsum of the hands or feet. And sometimes you see widespread purpuric eruptions with very unusual distributions, like what I have shown here. The lesions are basically confined to the upper part of the face and the upper part of the trunk, which is caused by echovirus. Actually, this type of picture, if there are neurological signs, one should also consider meningococcal sepsis. Now, in hand-foot-mouth disease, which is the common type of enteroviral infection, the child often has diarrhea, fever, and this rash, which is predominantly acral in distribution, not necessarily the palms and soles. As you can see, it can be quite widespread. And among the immunocompromised children, there can be a number of infections, like what we have shown here is a child with HIV, widespread molluscum, and herpes ulceration, chronic skin ulceration. Also, the child had cytomegalovirus. The child was blind in one eye and died of the illness. In severe combined immunodeficiency, the child can't clear the viruses, even including neonatal varicella. Here was a baby who had neonatal varicella, and despite treatment with IV acyclovir, the lesions did not clear. It kept on persisting and caused widespread destruction. As you can see on the nostril, there was widespread destruction. So in such scenario, one needs to investigate for severe combined immunodeficiency. Coming to other entities that you come across, now you can appreciate, apart from the the rash, the child is very sick. There is edema of the eyelids and a pustular rash. And this turned out to be the COVID dose and purpura. It mimicked Kawasaki and also had features of acute generalized erythematous pustulosis. So this is the multi-inflammatory disease that is affecting children and adolescents with corona. So again, we have observed the fever pattern, which was initially somewhat low, and then there was a saddleback, and then it started swinging. And as you can see on top, the various antibiotics had no effect. And IVIG and steroids helped in the recovery. Coming to bacterial infections, usually cutaneous lesions like impetigo does not give rise to a fever spike, but sometimes in streptococcal intertrigo, especially if many folds are involved, like the groins, neck, and the armpits, the child may be very toxic and feverish as well. This is a slide that Dr. Buddhini Disanayaka gave me with child with scarlet fever. Yeah, there's a widespread erythematous rash initially. Then you get papules and erythema, which when you touch it feels like sandpaper. And on the flexures and cubital fossa, you see petechial lines, which are known as the Castilla's line. Often they have a purulent lesions on the palate. On the coming to staph, various toxins can give rise to widespread damage, like staphylococcal scalded skin syndrome, and this is often severe in the neonate with many blisters. The pustular variant is invariably associated with fever, but responds very well. Sometimes it goes beyond the skin into the soft tissue and create a lot of problems in the management because of the problem of spread to the mediastinum. External gangrenosum, I started by showing you all the lesion start as the erythematous papule, becomes a pustule, then undergoes necrosis, sometimes with disastrous consequences like in the neonate, destruction of the nose and the eyelids. Purpura fulminans due to protein C and S deficiency can also sometimes give rise to spikes of fever, possibly by several mechanisms. Apart from complement activation, which is involved, they also can have a low-grade sepsis. Coming to Mycobacterium tuberculosis, this child had multiple abscesses, as you can see on the cheek and the body, and had a temperature which never ever settled with a number of organisms, and ultimately died, and it was proven that the child had metastatic tubercular sepsis involving many organs. Here is a child who presented with occasional spikes of fever, especially in the evening associated with night sweat, and he had this dactylitis with a discharging sinus in the interphalangeal joint. And the other place to look in these children is for hypersensitivity feature, the flictanular conjunctivitis. So this child responded very well to antituberculous therapy. So there the temperature chart is an occasional spike here and there. And when I say this about this immune complex thing, we have seen some unusual cases. This is a very, very tragic case where the child presented with fever and arthritis and was diagnosed as systemic concept juvenile chronic arthritis and started on methotrexate, and subsequently methylprednisolone was added because the ESR was 150 rheumatoid factor positive. And when methylprednisolone was given, the child developed gangrene of 2 fingers and also developed multiple abscesses which are as big as tennis balls. So this is subsequently he was diagnosed as necrotizing vasculitis secondary to atypical mycobacterial infection. He's now an adult and still he's on ciprofloxacin and clarithromycin, which we can't stop. So atypical mycobacteria can cause often mild ulceration or deep ulceration without causing fever. But in the setting of severe combined immunodeficiency, very young children are affected, the infants, and they have often a prolonged fever which hardly responds to the standard antibiotics. Still you give clarithromycin and ciproflox. And they don't give rise to a typical granulomatous reaction that you see in tuberculosis because some of these organisms are extracellular. We have seen number of necrotizing vasculitis due to atypical mycobacteria. He is another child, and these children often have a problem about clearing mycobacteria, the Mendelian problem that some of them have. Coming to typhus, the rash can be purpuric, involving the palms and soles, often papular on the rest of the body, with a little bit of hyperpigmentation. The erythema is hardly seen in brown skin. You have to flash a torch at an angle to see the elevation, the multiple papules. And you can treat it with 1 dose of doxycycline, which doesn't give rise to deep pigmentation. So you don't have to worry because it's a single dose of doxycycline. Eschar is hardly seen because sometimes we forget to look at places like the retroauricular fold or inside the ear canal. And that's a typical fever pattern of typhus. And we have seen number of children with melioidosis presenting with prolonged fever, multi-organ disease, oral ulcers, erythema nodosum-like lesions with pigmentation. That is one feature that we see in melioidosis. There's a lot of secondary hyperpigmentation among the lesions of erythema nodosum-like lesions. And they can have ulcerations. And this type of a fever pattern where the bacterial replication results in a low-grade fever. In immunodeficiency, this is Wiskott-Aldrich syndrome with herpes simplex infection, eczema herpeticum, and they bleed because of the quantitative and qualitative defect in the platelet. In Norman syndrome, again, the presentation is with erythroderma, fever, diarrhea, and marked edema and alopecia, because there's widespread immunodeficiency involving both T and B cells. In Netherton syndrome, again, they are predisposed to infections, and you see neonatal erythroderma and hair shaft defect, alopecia, and the classical cutaneous eruption. In hyper IgE syndrome, again, the neonates present with fever, and if you take a swab from these vesicular lesions, you find Staph aureus to be the most dominant organism. And initially, they respond to anti-streptococcal antibiotics, but with time, they go on to develop other infections like Candida, And if they have the DOCK8 mutation, they often develop infections with herpes simplex and molluscum, as you can see here. So invariably, these patients are stunted or malnourished, and they have spikes of fever here and there. And in classical hyper IgE syndrome, later on, they develop multiple abscesses, which are cold abscesses. They don't show the typical inflammation of an abscess. And it's often at times difficult to convince the surgeon that these are abscesses because there's no visible evidence of inflammation. So this is pyomyositis on the left side, and on the right side is a cervical abscess. Sometimes children with interleukin 12 or receptor defects, genetic mutations, develop widespread dissemination of BCG. Now, this is the X-ray of, again, the hyper IgE syndrome, showing the pneumatoceles and a widespread pyothorax, which ultimately spread to the pancreas also, and the child died of that. In leukocyte adhesion defects, there's an oncolysis, ongoing fever, and sometimes you see this hemorrhagic cellulitis. So these features help us to say that this is possibly this condition. And they also don't produce pus in the ulcers because the neutrophils can't leave the blood vessels. This is a child with congenital neutropenia who developed multiple abscesses and did not improve with antibiotics. Because the neutrophils play such a vital role in the defense against pathogenic organisms. Now, moving on to the other entities where you see fever and inflammation, which involves number of organs and the skin. And this is a child who had developed this digitate erythema with paniculitis, which ultimately resulted in dermatomyositis years later. Here is another baby who came with lupus paniculitis, and she was dsDNA positive at the time of when she presented with these lesions. Yeah, you can appreciate after treatment, even now the pigmentation still remains. And this is a boy who came with, I think we have a fever chart. Yeah, very unusual pattern of fever. Initially, it was continuously swinging, and then there were periods of normal temperature. With many antibiotics, he didn't improve. And he had these deep ulcerated lesions. Some of them mimic erythema multiforme, but remember, erythema multiforme is an epidermal entity, and here there are lesions which are even deep in the subcutaneous. And you can appreciate the heliotrope if you look closely. And the lesions on the face were localized to the mandible, which was unusual. And there was a discoid lesion on the ear, and there was bleeding into the eye. So he actually had a combined or an overlap with dermatomyositis and SLE. And he responded very well to treatment. These are the children who have developed dermatomyositis. The mechanic sense, which is associated with the antisynthetase syndrome, where there is lung fibrosis and arthritis. the Cochran signs. The flagellate dermatosis is sometimes seen like in this child. So these are curvy linear lesions compared to the stretch marks. Sometimes you see in atopy, which is also seen around the knee. These are curvy linear lesions. And here is another template chart of a patient with skin lesions. From this point, they went to Norelia, from Norelia to Kandy, and ultimately ended up at LRH. And by that time, there was gangrene of a finger. So this is the retiform purpura that the child had in the healing phase. If you see these combinations, you must interpret it as both small and large medium vessel involvement. And when you see necrosis, gangrene, for the polyarthritis nodosa, steroids and Dapsone is life-saving. I found that Dapsone to be an extremely useful drug in the management of polyarthritis nodosa. We have saved many children by using this combination. Now we are all familiar with pleva, but not many of us are familiar with Haberman disease, which is acute necrotic pustulovesicular variant of pleva, which is very rare. What saved this child's life is the combination of acitretin and methotrexate. You have to make certain hard decisions in clinical medicine, and one should not be afraid to use these drugs if indicated. So, child is completely normal now. We have managed 2 children for the past few years. And Kawasaki shock is another entity which we see from time to time, which is very similar to the multi-inflammatory syndrome of post-COVID, polymorphous exantheme. And these children, the dominant feature, apart from the very high fever, the hypoalbuminemia and the edema and the shock. So they settle, improve dramatically with both IVIG and dexamethasone. You can appreciate how the edema has made her look different when the edema settles with this treatment. Is another child, and some of them may develop the sign of psoriasis here and there because their disease is driven by mainly TNF alpha and also IL-17. So that's the temperature chart of Kawasaki syndrome and Kawasaki shock. It's very high, remittent, and it drops dramatically. It's the same child as this one. And with the treatment, the edema settles very quickly. You don't have to use albumin transfusions or FFP. That's the typical Kawasaki face. You see the red eyes, the dry parched, dry lips with cracks and bleeding, and the strawberry tongue. Cervical lymphadenopathy is not easily seen. Compared to toxic shock syndrome, there's perilimbal sparing of the conjunctival erythema. In toxic shock syndrome, it's diffusely, the erythema is diffusely seen. Here's another child with Kawasaki. Just to tell you all that the lips may not be cracked all the time, but the lips are dry. This is because of the damage to the small vessels. In long-standing cases, you see a lot of stuff which have accumulated on the lips, but you see that these children are very irritable due to ongoing cerebral vascular inflammation. It's the same child. And that's the perianal desquamation that you see in Kawasaki disease, the acute desquamation. The convulsion desquamation is seen on the fingertips. Polymorphous exantheme and the perianal desquamation that you see in acute Kawasaki. The penile tip inflammation. The pustular lesions are sometimes seen. Often it's a localized pustular rash that you see on the knees and the elbows, but sometimes you see widespread pustular eruption associated with strawberry tongue. And we have seen a couple of children with pustular psoriasis and Kawasaki, which we have published earlier. Yes, this is toxic epidermal necrolysis. And this is dapsone hypersensitivity syndrome. As I said earlier, the liver plays a crucial role in the production of, in the propagation of fever by producing various compounds, including prostaglandin E2. Sometimes we see neonates with pustular eruptions, and when it is so widespread, you have to consider certain inherited disorders like deficiency of interleukin receptor 36, the ITRA, and sometimes interleukin receptor 1 deficiency, DIRA. Unfortunately, we don't have anakinra, which is the ideal treatment for treatment of interleukin-1 mediated periodic fever. So instead, we use citratin and also steroids. So this is a child with DITRA. This is the typical pustular psoriasis rash. You see lakes of islands which fuse and give rise to these brown pigmentary dots. You don't have time to arrange investigations when you see this type of sickness with very severe temperature and low calcium. You need to commence them on treatment. Sometimes you see mild changes in the mouth, like what is shown here, superficial ulcers, and the child also had few skin lesions. And that is actually the mycoplasma induced rash and mucositis mumps, where you don't see many features of eczema multiforme. This is a baby that was referred by, I think, the surgeons. The child didn't have had a very necrotic lower lip which had disappeared, and at NHSL they have reconstructed the ulcer a few days earlier, and the child had basically eaten it again. So when you see this, the child also has other congenital abnormalities you can appreciate. You must look for evidence of congenital absence of pain. Otherwise, sometimes they can suspect abuse here. In fact, abuse was the #1 diagnosis that they have entertained. So in familial dysautonomia, basically they, as the children grow up, during their infancy and neonatal period, they have very high fever and autonomic disturbances. But later on, they eat the tongue, like in this patient. And in the previous one, the child basically eats the lip. From time to time, we see these babies with fever and widespread erythematous rash, what are shown here. Very tragic child, actually. We could not save this child because of the multi-organ damage. They came very late. And you see a fever pattern which which shows periodicity. So there are many conditions now under the autoinflammatory syndrome. The number one is to demonstrate the periodicity. So this is the sweet-like periodic fever syndrome. The current classification focuses on the etiology, whether it's IL-1 or interferon gamma, or they are regulatory genes. So there are about 20-30 new entities with specific features. But for most of them, including DIRA and LITRA that I showed, are now classified under the periodic fever syndromes. And this is the key. The periodic fever tells us that it is autoinflammation. And however much antibiotics you give, there won't be any clinical improvement. There is another child with neonatal sweets, with widespread damage. And this is the first case that I diagnosed with periodic fever syndrome. She was an infant coming from Alsaville, and the patient had received more than, I think, 10 different antibiotics over the time. And she's now grown up. You can appreciate that she's cushinide because we don't have anakinda. We have to use steroids. And also we use simvastatin, which is involved, which inhibits the synthesis of certain cytokines. And she also has acromegaloid peripheries because of persistent widespread systemic inflammation. And these are her hands. She's Aditya, and that's her fever pattern, which I have shown her, shown you all. But she's a very talented girl, actually. This is something that she had drawn and written something. And we still struggle with her in the treatment. We have tried Dapsone, it didn't work. But it worked for this baby with CBDC, an infant with widespread CBDC. She was very sick with low albumin and widespread skin lesions. We had to give steroids. I had to use Dapsone. Initially, I started on a low dose. And when we increased, there was marked methemoglobinemia. And the hematologist insisted that we stop the drug, which we didn't do. The decision to continue is ours as clinicians. The specialties can make recommendations. My argument was, if we stop Dapsone, what are we going to give? And as you can see, the child is doing very well now, completely free of disease. And currently on, I think, either 25 or 50 alternating doses of Dapsone, which is a wonderful drug. So in the setting of Dapsone hemolysis, if the total hemoglobin is, say, 10 and 10% is methemoglobin, that means 1 gram of hemoglobin is not available for oxygen transport. If the cardiovascular system and respiratory system is normal, the child has 9 grams. Don't worry. Continue with the Dapsone. This is exactly what we did. And the child is doing very well. And that's a genuine smile of a child who had done very well. And thank you very much. I would like to thank Dr. Subhani Pereira for her help with putting all these slides together. I'm sure I have missed so many, but I think that's a reasonable overview of fever and rashes in children. Thank you.
Salanki, you are on mute.
Yeah, sorry. Thank you very much, Professor, for your very insightful and informative lecture today. So before starting up the question and answer session, if delegates have more questions, I kindly request them to write their question in the chat box. And while writing, I will take 1 single minute from all participants to play a video of Glenmark's latest launch in the therapeutic area of acne, Deriva CMS. Varun, can we have the video?
Okay, can I speak now?
Yes, sir, please.
Thank you very much, for that very interesting, actually containing so much of rare and some of common conditions. And also, other than just showing the clinical entities, you have included pathogenesis of fever as well. I learned that there is a bit of problem of forwarding the questions to the chat box. But anyway, so I would like to know something regarding the pathogenesis of fever. Now, does fever serves a physiological function, like in when it is in infection? So, is there a beneficial effect of fever?
A very good question, Janaka. Thank you. Fever is very physiological, and when the temperature rises, most of the human pathogens have a replication temperature of less than 37. That's one. Number two, our adaptive immune responses work very well when the temperature is high. That's two. The third point is certain antibiotics, it is now known, act better at a higher temperature. So, can you hear me?
Yes, can.
Yeah. So, number one is the most important one. Most of the microorganisms, both bacteria and viruses, replicate at temperatures either at 37 or below. Now, number one is tuberculosis, which replicates at 37. Leprosy and other mycobacteria, much less. You know the same of leishmaniasis, which we use in the treatment. Therapeutic modality heat is used. So it serves a physiological function, but it's also fever that causes a lot of discomfort to the patient. So this is why the antipyretics are being used.
And
in other words, by lowering the temperature, we may allow the microorganisms to multiply.
Yes, I think then we have to specifically give the specific treatment at proper time rather than keeping the temperatures low with antibiotics alone. So there is one question from the audience. Is the fever is a common finding in atypical Kawasaki disease? What is the usual duration? And can it be absent? That is, can fever be absent in atypical Kawasaki?
Yeah. In atypical Kawasaki, actually, the typical features are not seen, like the very high temperature. What you may see is one feature, like maybe a red eyes or a red mouth, which can occur in many other conditions. So fever is the most common feature of Kawasaki disease, both in typical and atypical. But the other features may be absent in atypical Kawasaki disease.
Now, I think in Larich, there was sort of a surge of COVID patients during last couple of months. And now in COVID, there are certain skin eruptions described like vesicular eruption, which are sort of much more specific for COVID and COVID dose. And also the common ones like urticaria and maculopapular eruptions. How is your experience? Do you get any referrals from the COVID and sort of with this associated skin eruptions, or are they
we saw only the one that I saw is the one that we showed, which also had a lot of pustular lesions, which made me think initially of acute generalized exanthematous pustulosis. And I think Sriyani who ordered the antibodies for the COVID and came positive for that. So it was actually number of cutaneous manifestations were there in that patient.
So are there patients being referred from the COVID ward, so where they manage the COVID patient?
Not really. I think they forward the pictures. I haven't seen many actually.
But there are many cases, so and
there had been cases.
So they,
but I think what happens is once the diagnosis is made based on of the PCR or the antibody, they manage to refer, the theoretical risk of theoretical and actually real risk of spreading the disease, maybe limiting them the number. But I think, what is your experience at the NHS? Did you all see a lot of cases?
No, that is the same with us actually. Now, I think about nearly 100 patients were there for the last couple of weeks in NHSL. Some of them have been transferred, but some of them actually remained in the same wards and then discharged, but hardly any referrals we got. And I feel that whether they are being overlooked or because they are not life-threatening, probably they are not attended. And so one more thing I just came to my mind. So you spoke about Dapsone. Now, during these couple of years, we had several cases of Dapsone-induced agranulocytosis.
Yeah.
So in LRH, do you have any experience with the use of Dapsone? And
no, I have used it actually. To tell you, I have been so lucky. I have used Dapsone since I moved to Padulla, 93. I'm fortunate that none of my patients have died of any complication of Dapsone. I haven't come across any granulocytosis in my practice. They've not at LRH. And we have had many number of Dapsone hypersensitivity syndrome. And we had Imali, that is, she developed DIC following Dapsone hypersensitivity and chickenpox, varicella. I think you are familiar with that case. But even she survived. We use Dapsone more for inflammatory skin diseases than for leprosy at LRH. That is mainly chronic bullous dermatosis of childhood, polyarthritis nodosa. I use it along with steroids, and Sweet syndrome. We haven't had a single case of agranulocytosis. But I think in the setting of leprosy, it's different, no, from your experience, adult patients with leprosy.
Yes, now actually now in NHSL also we luckily we didn't see much sort of very serious issues other than a couple of deaths on hypersensitivity syndrome, and we have seen one or two agranulocytosis cases, sometimes which were being transferred to NHSL, but in certain places actually. Even recently, there were several cases of agranulocytosis. And so these days, the dengue fever is also in the rise. Do you have, I mean, do you get patients with this typical dengue skin eruptions or?
Yeah, now I showed you actually my presentation had nearly 150 slides. So my experience with dengue is that apart from the dengue convalescent rash, if they go into shock, they develop a lot of necrotic lesions, which I have a series of slides somewhere showing cutaneous necrosis. And sometimes these children are when they are ventilated, they develop ischemic necrosis of the scalp, where the head is kept on in the intensive care unit, and also they develop telogen effluent and related problems. That's what I have seen. Have you all come across anything else, Janaka?
Not much, sir. Sometimes, other than the porphyric patches, sometimes we see this purpura with sparine areas, the islands of sparine, that type of skin rash. So I think I must thank Professor Jayamini Seneviratne for that excellent presentation, and very interesting and very informative and sort of educative for us. And because especially the pediatric cases, I mean, when we get fever and rash, that is something which we have to be on toes and decide then and there. So thank you very much, sir, for your nice presentation. Over to you, Prof.
Good evening, doctors. We have come to the end of the inaugural virtual CME of Dermakonnect Sri Lanka in association with the Sri Lanka College of Dermatology. First of all, let me thank Sri Lanka College of Dermatologists and our today's speaker, Professor Jayamini Seneviratne, in delivering today's lecture. So thank you very much, sir. Thank you very much for your insightful presentation today. And also, let me take this opportunity to thank today our moderator, Dr. Janaka Kavita, for his coordination and conducting today's session. So thank you very much again participating with us by allocating your valuable time. And also, it is with great pleasure I thank all the medical professionals, those who have joined and make this CME a successful one. So thank you very much, all the doctors. And let me also inform you, we will be updating our next Dermakonnect Sri Lanka session very soon. So thank you very much, everyone, and good night.
Thank you so much.
Thank you.
වෙලා වගේ තිබුණා.